Okay, let's get started. Good morning in Europe, good afternoon in Sydney, and welcome to all the attendees and guest speaker to this savings sarcoma educational session with this IMPERAS project. Thank you for being here. We encourage to all participants to submit questions or remarks by using the chat box. The question will be addressed right after each presentation to be more interactive with the speakers. This time we have a speaker from Australia and Spain, and we really appreciate the willingness from an Australian speaker to join us at this time, 10 hours ahead in Sydney, and also to Dr. Samuel, and as well as all the attendees to join us very early in the morning here in Spain. Sorry, but it is the only way to do live session. This is the time. It is now my pleasure to introduce our first guest speaker, Professor Fiona McCleans. She is Senior Histopathology from Douglas Handel Mori Pathology and Clinical Associate Professor Macquarie University in Sydney, Australia. She is the current president of Australasian Division of International Academy of Pathology. As you surely know, she is an international expert, and she has many contributions in bone soft tissue pathology, as well as genitourinary pathology. Thank you, Fiona, for your time, and we are looking forward to invite more pathologists from Australasian Division to this session. Please, could you share your screen, if you don't mind, and start your presentation?
I will. Yep, hang on, I'm almost there. Hang on. Can you see that now? Not yet, hang on. Let me just share and then, okay, you should be able to see that now, yes?
It's okay.
Good, okay, excellent, good. All right, so I've put my my Twitter handle here and also the Twitter handle for the Australasian division of IAP. So we're trying to put up a case of the week each week, and because I like sarcoma, sometimes it's sarcoma. So if you'd like to follow us on Twitter, the second Twitter address there, you should look out for our cases of the week from Australasia. They're actually quite interesting and fun. So I know you've had a whole range of different topics this year, so I thought what I would do was actually talk about something completely different, but from a sarcoma perspective. So I'm covering bias and the pathologist, mainly because Isidro said to me, don't talk about molecular. Everybody talks about molecular. So there is some molecular in this because it's a sarcoma talk, and sarcoma is very molecular now, but this is also not about molecular. It's about us and inside and how our brains work. So just to start with, if you think about when you look at a rainbow, we often see distinct colours. You see all the different colours of the rainbow. But we know in our heads that actually a rainbow is a spectrum. It's a continuum of colour. It's not actually distinct like that. But because we're pathologists, we like to categorise. That's one of our desires in life, is to categorise. So we try and categorise, and we just do it automatically. And so our brains put the rainbow into different colours when it's really a spectrum. And we do that with our tumours as well when we're looking at them. So we normally start with morphology. That's the easiest way to categorise. So for sarcoma, you might be thinking small round blue cell tumour or something like that. You can also go for lineage. That's another good way of categorising. Or these days, we know about underlying molecular alterations. So you can go for molecular techniques. So commonly, we would use FISH or next generation sequencing in our sarcoma work. But now there's the advent of novel immunohistochemistry against the fusion proteins. And so we can use those instead of actually using the molecular techniques all the time. But just remember, sometimes pattern recognition can be a bit misleading, and your eyes might trick you into thinking that you're seeing something that's actually not there. So, you can see a pattern like this and get confused. So just be aware when you're looking at patterns, they may not actually be very representative of the actual true tissue. So when we think about mesenchymal tumours, they're a heterogeneous group, and the classification is evolving. And often initially, as pathologists, we will classify according to the morphology, the patterns. If you look at all of these tumours on the right-hand side here, they do look to be quite different. They're not very similar at all, but it's interesting because these are all rhabdomyosarcomas. So if you went on morphology for these, you could be trapped. So we have these cognitive biases in our lives. And look, this is actually really important to have cognitive biases because we get so much information coming in all the time. So you're probably getting information about my voice, my hands moving around as I'm talking, the temperature of the room you're sitting in, any noises in the background, you know, how the seat feels under your bottom. All of these different things are coming into your mind, but your mind is actually filtering out that information because you're getting too much information to deal with. And so biases are actually really important to be able to just live our lives. And there are many biases that we have in life. So you might have heard of the anchoring bias, which the first piece of information you get, you tend to anchor onto, or maybe the first diagnosis you think about, you tend to anchor onto and think that that's going to be more likely. The fact that people think they're not biased, but everybody else is biased. I'm not biased, but you are, you know, that type of idea. And the bizarreness effect. I don't know if this saying is true in Spain and in Europe, but we have a saying that if you hear hoofbeats, think about horses, not zebras. Because if you go to an exam for a pathologist, they always think about the really rare things when they're listing off the different differentials, but not the more common things, because you actually remember the bizarre things much, much better. There's also things we do to sort of plan our day. So, you know, when you plan to write a talk, like I planned to write this talk, it took me much longer than I planned because it always takes longer than you plan. And that's a planning fallacy. That's something we all have. And then there are other things like the IKEA effect, which means if you built it yourself or you had your hand in making it, you're much more likely to believe it or trust it. So if you set up the classification system or you are part of the classification system, you're going to back that system a lot more because you trust it a lot more. And then the overconfidence effect, which is if you haven't really got experience in a particular area, you actually think you're more confident and think you're actually more skilled in that area than you really are. So, you know, it is hard to try and put these biases into perspective. And, you know, the biases are good because it stops us from getting too much information overload, but we miss things and we conjure our own meanings in things. And sometimes quick decisions may not actually be good decisions. So you might remember this dress from a few years ago, went through the internet, and some people saw it as gold and white and other people saw it as black and blue. And it was their cognitive biases for, you know, how to interpret this type of picture. And, you know, this dress now, if you saw it in one color, it's really hard to see it in the other color because we actually reinforce our errors with our memories. So this is the case, the main case that I'm going to present, which was a 61-year-old female. She was said to have on imaging 2 separate upper pole tumors within her kidney. And she had a past history of lobular breast carcinoma a few years before, and about 18 months before presentation, a high-risk melanoma. And this was the lesion. It had 2 components, as you can see, and here it actually extended outside the kidney and abutted the adrenal gland. One component looked more like a regular angiomyolipoma. It had fat and it had these myoid components. And then this other component, it had a few different appearances, but it was this high-grade epithelioid appearance. You can see it zoomed in here. And so the 2 areas actually were quite distinct, with almost a line between the 2 of them, differentiating these 2 pieces of tumour, completely different appearing tumours. And even on the immunohistochemistry, there were differences. So you can see this is the Desmond stain, and you can see the Desmond was staining the angiomyolipoma, but not staining the high-grade epithelial tumour. This was the HMB45. It actually stained both components. The SMA, again, stained the angiomyolipoma, but not really the epithelioid tumour. And this one was the SOX10, which was negative in both components. S100 was just faint and patchy within the epithelioid component, but completely negative within the angiomyolipoma component. So I thought about it, and I thought, given the history had been given to me at the beginning, I actually favoured this to be a collision tumour with an AML, a regular AML looking, you know, benign, with collided with a metastatic melanoma. But I couldn't really exclude a malignant PComa. I do a lot of urogenital work as well, and I've seen, you know, hundreds of PComas. But I'd never really seen one that had this sort of appearance, like a malignant component like this, with a really distinct line with a sort of normal-looking angiomyolipoma. So I thought probably a collision tumour was what I thought it was going to be most likely, especially with that history of melanoma. The problem with melanoma and PCOMA is that they have overlapping morphology and immunohistochemistry, and different prognosis and management would be the situation for this lady, depending on the diagnosis. So I actually suggested what would be good would be to compare with the previous melanoma, which was at another institution. And that melanoma, when I got the report, was strongly positive for SOX10, S100, melan-A, and HMB45. And this was the slides that came from the other institution, and you can see it did look a bit different from the epithelioid component within the kidney tumour. So it was more nested with more clear cell appearance and had hemosiderin deposition, which I didn't see within the tumour. Here in Australia, we can do molecular analysis for targetable BRAF, NRAS, or KIT mutations in metastatic melanoma. So I went ahead and did that because that's covered under a government rebate. And you do see that in 50% of metastatic melanomas. So I thought that would be helpful if any of those were positive, but none of them were. The other thing is PCOMAs can have a subset which have a TFE3 rearrangement. So I did TFE3 immunohistochemistry and then TFE3 FISH, because I thought if that was rearranged, then that would confirm it as PCOMA. Well, neither of those things helped. And so one of our sister institutions, they actually offered a custom NGS panel that they put together, so which included a TERT promoter, which you normally see in melanoma, looking for the loss of CDKN2A, which frequently is in melanoma, and TP53 mutation analysis, which you would see in PCOMA. So this pattern hopefully was going to help us really nail down whether it was melanoma or PCOMA, because this would make a difference to the patient. And this is our table of how the tumour appeared. So the primary cutaneous melanoma had a different appearance. The kidney tumour, the low-grade region, looked like an AML. The high-grade region was somewhere in between. So three tumours actually looked different, or each tumour looked different from each other. And the immunos actually overlapped. It was difficult because there was overlap between all of them, and pointing out that the S100 was actually positive in the epithelioid tumour of the kidney. But what really nailed the diagnosis were the molecular features. So that special NGS panel that was constructed showed that the melanoma, which is this column on the left-hand side, actually showed the changes that we expect in melanoma with the TERT promoter mutation and the CDKN2A mutation, whereas the PCOMA had a TP53 mutation, and that high-grade epithelioid tumour also had the same mutation. So therefore, the tumour in the kidney was basically a AML, angiomyolipoma, which then had a very discrete cutoff and moved into this malignant PCOMA component, so not a metastatic melanoma. So it actually changed my diagnosis, being able to do this. But I think what had happened was I'd got the history on the form saying history of high-risk melanoma recently. And so in my mind, I live in Australia. We've got the most melanoma cases in the world. You know, we're a high-risk melanoma country, too much sunshine, a bit like Spain, all the sun. So, but not the dark skin. So, you know, we all end up with, you know, hopefully not everybody, but a lot of people get melanoma here. So we see lots of it. So I'm already predisposed to think about melanoma in every case I look at. Now, this lady was really interesting because at the time of the resection of the kidney, the margins were clear, but she actually went on to develop this paraneoplastic cerebellar dysfunction syndrome where she had nystagmus. So she was a teacher and she was actually able to go back to work after she had her kidney out, but then started developing this nystagmus, which was quite debilitating. And, you know, it was investigated and thought to be this paraneoplastic syndrome. So by about a year after the kidney surgery, she'd actually went for a retroperitoneal lymph node dissection. And we did identify lymph nodes with metastatic PCOMA in them. Once the lymph nodes were removed, her nystagmus went away and she was able to go back to work again. She was then treated with an mTOR inhibitor, but there was lymph node recurrence again. And as the recurrence happened, her nystagmus came back again. And so again, she's had a lymph node dissection, and as the lymph nodes were taken out again, the nystagmus has gone away again. And just recently, in the last couple of months, she's actually developed nystagmus again. So we think she's probably got another metastasis somewhere, and we're just looking for that now to be able to debulk that area. Given the interest and the unusual presentation of the case, material was sent for foundation medicine analysis. And interestingly, given this is a PCOMA, there was no mTOR pathway alteration identified. So they suggested a potential alternative driver through maybe c-MET or some other mechanism. And the oncologist has actually asked if we can do c-MET immunohistochemistry. We don't have that available, and I can't find anywhere in Australia that does have it. And I was just wondering if anybody else, at the end of the presentation, if anybody could mention if they actually do have c-MET immunohistochemistry available, that would be very helpful. But they didn't actually find a pathway alteration in their molecular analysis anyway. They were just raising that as a possibility. So angiomyolipoma is part of the perivascular epithelioid cell neoplasm PCOMA family, and presents with both positivity for muscle markers and melanocytic markers, including sometimes S100, which was a bit of a trap in this case, with the epithelioid tumour being S100 positive. And a subset are TFE3 positive. A subset are also associated with tuberous sclerosis syndrome, and it's only really the epithelioid variant, or what we would call PCOMA in the soft tissue world, that has malignant potential. And here's an example where you can see all three components. This one has the vessels. Now, the vessels are quite interesting because they don't have proper elastin in their walls. So if these get cut into at the time of surgery, they'll actually keep bleeding and they don't clamp down like a normal vessel would. And so that's why the common presentation for angiomyolipomas of the kidney is a sudden bleed with renal angle pain presentation to the emergency department in the middle of the night, because they tend to bleed and they keep bleeding because of the vessels. Here we have the myoid component, and this is HMB45 and melon A. I always order both HMB45 and melon A because often one is stronger than the other, and sometimes one can be completely negative. We do see ones with predominant components, and so this is one that you can sometimes see in the capsule of a kidney, and it used to be called a capsuloma, and it's a spindle cell predominant AML, which is leiomyoma-like, and you can see here this variant. And this one was HMB45 positive, but really only around the blood vessels. The melon A was actually negative, completely negative in this one, and that's the desmin. So you could have mistaken this one for a leiomyoma because the desmin was the strongest staining stain. And we also see ones where it's just virtually completely fat, so a fat predominant one. And this is one that had some little vessels in it, HMB45 and melon A. And this is a really interesting one that I had where this is an invasive urothelial carcinoma, or TCC, invading into a fat predominant PCOMA. And on the initial sections when I was looking at them, I wasn't sure whether it was a urothelial carcinoma invading into the fat within the renal sinus. It was only when I went back to the macroscopic kidney specimen, I realised that it was actually invading into a fat predominant angiomyolipoma. So it was a really interesting case. And you can see here, sometimes the fat that's present can even mimic lipoblasts. So you might get, you might mistake it for a liposarcoma, so just to be aware. And this is the HMB45 on that case. You can see the nests of epithelial cells, which is the urothelial carcinoma, and the HMB45 staining the background fat. You can see sclerosing PCOMas. This one has a more normal looking PCOMA on the left-hand side and a sclerosing component on the right-hand side, where you get these dense bands of sclerosis. And these are often gynecological or retroperitoneal. There's a AMLEC, which is an angiomyolipoma with epithelial cysts, and sometimes the cysts are quite predominant and it can be difficult to identify the background angiomyolipoma. So with epithelioid angiomyolipoma, these are defined as the presence of round to polygonal cells, and you get these predominant nucleoli, sometimes with pseudo-inclusions. And, there's been a bit of a debate recently about how much epithelioid component is required to call it epithelioid angiomyolipoma or PCOMA, which would have malignant potential, and 80% has been suggested. They'll be negative. This is a keratin stain, but they'll also be negative for PAX8 if it's a kidney tumour. And this is HMB45 and melon A. So the criteria for malignancy, you look for size, infiltrative growth, nuclear changes. Mitoses only need to be 1 or more per 50, so it's actually quite a low mitotic count you're looking at, areas of necrosis or vascular invasion. If the tumour is quite small, but with atypia, but no mitoses, it can be considered to be benign. But if you have nuclear pleomorphism, including multinucleate giant cells like this case here had, or it's over 5 centimetres, best to call it uncertain malignant potential. So context effect, it's when the influence of the environment affects how you make a decision on something. So these are my cats. They look like they're identical, they're brother and sister, they are twins. But when you read the sign here, the cat, can you see that the H and the A are actually exactly the same shape? But you read one as the and the other one as cat because you're reading them in context and your brain automatically sees it in the context it's in. You might think about sometimes if you go to the supermarket and you see somebody you know, but you can't quite remember their name, you can't place them, and it's actually a close work colleague, but because you're not seeing them at work, you can't place exactly who they are, and you're a bit embarrassed because you forget their name, but it's the person in the office next to you at work. And this is this context situation. So sometimes when we see a tumour in the wrong context, it's actually really hard to place exactly what the tumour is. And so this was a skin tumour. You can see here it's got clear cells, nesting, and this is HMB45. So this was actually a cutaneous pecoma. So we need to think about them at other locations. So cutaneous ones often have this clear cell appearance, and they can show more variable staining. This is a 59-year-old who presented with PV bleeding. This was from her cervix. So this is a cervical lesion. That's the HMB45 and the melon A and the Desmond, and this was TFE3 rearranged. So this one's actually the TFE3 immunohistochemistry. So this one was another pecoma, a primary pecoma in the cervix with a clear cell appearance. Now, I've been talking mainly about pecomas. I was just going to talk quickly about some other biases, talking about some other myeloid tumours with myeloid differentiation. And one of the things that is a bias is if you've never seen something before, it's very hard to diagnose it. So if it's a rare tumour, like a lot of sarcomas are quite rare, you might not have ever seen one, or you only see it in a textbook, one photo in a textbook, and that's the photo you have in your mind when you're trying to make the diagnosis. But we know sarcomas can look quite different. Even those pecomas I just showed you all looked very different from each other. So sometimes it's really hard to identify a tumour if you haven't seen enough of them because they're rare. And so we do tend to categorize things according to our past experiences. And so on the internet, I was reading about this, and they say, okay, well, if you're an adult and you look at this picture, you see an intimate photo of a man and a lady. But apparently, if you're under 8 years old, you look at this, and because you're not used to seeing intimate pictures like this, what you see is dolphins. You don't see a man and a lady. And so I thought I would try this out on my daughter, who was under 8 at the time. And I said to her, darling, what do you see in this picture? And she went, oh, mummy, I see a man and lady, and they like each other very much. And I said, oh, don't you see dolphins? There are dolphins. She said, mummy, there are no dolphins in that picture. And I just want to prove that there are actually dolphins in the picture. There are the dolphins. I've highlighted them in blue for you. But so, you know, this was the sort of principle that it was supposed to work, but I learned a couple of things from this. Don't trust everything you read on the internet, and maybe don't show your children porn is probably another good life lesson to learn from this. So this law of past experience, this is a case I only had a couple of weeks ago, and this was a patient who was 57, and she presented with incontinence and lower limb paresthesia, and this extradural mass of about 3.5 centimetres. We found out later she had a background history of systemic lupus, but that wasn't actually given initially. So the tumour looked a little bit like this, and I actually thought about pecoma when I saw this tumour. That was the first thing I thought of because I've seen a lot more pecomas, and that was where I went. So I saw this myeloid-looking tumour with spindle cells and eosinophilic cytoplasm, some vessels, some areas where there was clearing around the cells. You often see clearing like that with pecomas, and there's more round cell component. There were lymphocytes in the background as well. This one was SMA positive, and this is the Desmond, and I thought, well, that's actually quite good. It's probably a pecoma. We should order a HMB45 and a melon A. Well, they were negative. I was quite disappointed. And this is actually what was positive, and it's the IMPERAS. So, because I thought about it, and I always order an IMPERAS on these low-grade myeloid-looking things. but I'd never actually had one before. So this is an EBV-associated smooth muscle tumour, and I think her immunosuppression was associated with her SLE. So this is an uncommon neoplasm, usually associated with immunodeficiency. You usually see intratumoral lymphocytes and round cells, but you have a low-grade spindle cell component as well. And the diagnosis is that demonstration of EBV via ISH. So this was the case for Isidro, which was the non-molecular case that I was able to diagnose last week without having to order any molecular. So that's especially for you. And then this one was another one we had a couple of weeks ago. This was a small little yellow, it's only quite tiny. You can see it's only a few millimeters across. Yellow lump noticed on the side of this tongue of this 54-year-old. The biopsy was a little bit disconcerting though. It was myoid looking with a myxoid background, spindle cell, some round cells, and atypical mitoses that were readily identified. And this is the desmin. So it was again a myoid tumour with desmin. This is the myogenin, and this was the myo-D1. So you probably all know what this is. I think you might have had one of these cases presented earlier in the year. Spindle cell or sclerosing rhabdomyosarcoma. But they have to start somewhere. They have to start really small. But my bias was that it was so small that I didn't really want to call it that. I was anxious about calling it that because it was only, you know, a few millimeters in size. But I did actually send this one away for confirmation with another soft tissue pathologist because I thought it would be important that it wasn't just me calling it on this because she's going to have a hemiglossectomy now. So I think that to make that diagnosis and that management for such a small tumour, I wanted to be sure. So this is another case I had, another head and neck one. And these are often associated with myo-D1 mutations. And you see this diffuse myo-D1 staining. So you know, you need to see them and see a few of them to get under your belt, you know, what they look like. And I think I just had one. Somebody came in 5 minutes ago before the meeting started, and I've just got another one, which was quite unusual because it had a lot of sclerosis in the background and it actually looked a bit pseudovascular. So they can have a range of appearances. This is one I had a few years ago that I had Sanger sequencing done on and showed the myo-D1 abnormality. But it's usually the non-congenital ones which have the myo-D1 and they tend to be more aggressive in that age group. Now, I'm almost coming to the end, but there's a thing called inattentional blindness. So that sometimes when you're busy doing one thing, you kind of ignore what's going on behind you. And they thought, oh, well, it's, you know, for people who are not really practiced at the task they're doing, you're so busy doing the task that you can't think of what else is going on. But they actually looked at it in experts. And so they looked at radiologists. They got 24 radiologists and they got them to look and do a familiar task. So they got them to look at CT of the chest and asked them to look at lung nodules. So they said, okay, so lung nodules, you know, what do we see? And in fact, what actually happened was that the people were so engaged in the task that they missed a much bigger thing on the field, which was this gorilla up here. So it was interesting because they tracked the eyes of the pathologists, and the pathologists actually looked at the gorillas, the radiologists actually looked at the gorillas, but ignored them. They didn't even register in a cognitive level that they'd seen the gorilla, and the gorilla was quite big compared to the nodule. So we can also show inattentional blindness, and this was a lesion that came from me only a few weeks ago. Somebody wanted me to confirm leiomyosarcoma in a scrotal mass. And you can see it looks myoid. The SMA was positive, the desmin was positive, there was some high-grade nuclei and some mitoses, but when you actually looked in the background, there were these hyperchromatic atypical cells you can see here. And I found a lipoblast. And so you don't have to find a lipoblast, obviously, to make this diagnosis, but I did. And the MDM2 fish, you can see that the red signal was very amplified. So this was dedifferentiated liposarcoma. So one other thing that we have is this pareidolia. I don't know how many of you see faces sometimes down your microscope. I often sit here late at night looking at prostates, and the later it gets, the more faces I see. But these are the faces of my prostates and other things that I've seen over the last years, usually late at night by myself. But it's one of the ways that we, you know, can interpret the world, and it's another bias that we have. So there's evidence that wandering minds predict unhappiness. So I hope you weren't wandering too much and thinking about other things while I was talking, because it would have shortened your telomeres and your load of genetic errors is increasing. So hopefully it was worth the time for this talk. But what really is worth the time is I'm just going to do a quick plug for our international IAP meeting. The big international IAP meeting that happens every 2 years is on in Sydney next year. So we've got a hybrid meeting which has virtual components. So if you can't come to Sydney, you can participate virtually, but we'd love to see you in person. It'd be really great to welcome you to Sydney and even show you our lab. Christina and I work in the largest lab in the Southern Hemisphere. So if you do want to visit, if you come to Sydney, please come and say hello and we'll show you around our lab. Sorry, I went over.
Okay, thank you very much, Fiona, for your nice presentation. I enjoyed pretty much. So I have a free question, and I will ask later if any other attendees have a question. So my first question is that I guess that this is very difficult, the differential diagnosis, not only in Australia, also around overseas, between the differentiating melanoma and this type of sarcoma, because you show these two patterns. So, you know, this differentiating melanoma is very difficult to exclude, in particularly in this patient with some previous history of also melanoma. So my question is if there is any histological clues that can be helpful for this differential diagnosis. This is my first question. My second question is, there is already described some pattern of the differentiation in sarcoma. This is my second question. So when you're talking about malignant sarcoma, we can see this both pattern of low grade and high grade, and we may say that that's a differentiated sarcoma, or is the same to say this is malignant sarcoma. This is my second question. And my last question is about, do you think that it would be important to test ever cyst or ever anywhere in all muscular tumor or soft tissues tumor with muscle differentiation?
Okay, so let me answer the second one about dedifferentiation versus whether I would call it dedifferentiated or malignant sarcoma. So there was a question that just came through on the chat just first before that, which was, what was the final diagnosis? Was it a collision tumor or was it a malignant sarcoma? It was malignant sarcoma because of the molecular findings. So initially I thought I favored a collision tumor, but I was wrong. So the molecular actually sorted this one out, and it was actually a malignant sarcoma. The second question you had, which was about whether to call it malignant sarcoma or dedifferentiated sarcoma. Yeah, I think in the literature, most of the time it's referred to as malignant sarcoma. I think that really clear line made me feel that it was almost like a dedifferentiation because, you know, when you get dedifferentiated chondrosarcoma or liposarcoma, you're looking for a line, you know. When you're trying to diagnose low-grade dedifferentiation in liposarcoma, I need to see a line to be able to make that diagnosis. Like, you know, it's one of the things you look for dedifferentiation. So the line, I think, you know, makes any soft tissue pathologist think about dedifferentiation. But in kidney, I've had quite a lot of sarcomas. So I get about 900 kidney tumors a year, and in kidney, I've had a lot of sarcomas where there's actually been a fairly good line between the benign component and the malignant component, or even just between the AML looking area and the epithelioid component. So I think it is something we see in kidney. I'm not sure if it would be the same if this had arisen in soft tissue instead. So I favour this to be a malignant sarcoma. The term dedifferentiated sarcoma really isn't used that often in the literature, and if you look back, it's mainly old cases and it's mainly not in series. It's usually one case report, and it's often people who, you know, don't do a lot of that work. So I think that, you know, the term you should be using is malignant sarcoma in this setting rather than dedifferentiated. Although I do get the line makes it look dedifferentiated.
Okay.
So now the first question was
about the ever in muscular differentiating tumor. Should we do ever in all
Oh, EBA-ish. Yeah. So I think, yeah, the EBA-ish. I only tend to do it in low-grade looking tumours. So normally I mean, I don't have a lot of experience with these tumours because they're quite uncommon. We have a combined meeting with another sarcoma unit every Friday afternoon. And because that's a public hospital and the patients there tend to have more immunodeficiency, I've seen a few cases through that hospital. But because we work in a private facility, we don't have as many immunocompromised patients. So that might explain the difference in numbers. I think they've had 2 or 3 cases over the last 15 years, and we've only had this one case. I think normally I will order the EBA-ish if it's a spindle cell low-grade tumour, especially if there are collections of lymphocytes. I think the lymphocytes are quite important. And if you see that area with the clearing around the round cell morphology with clearing, I think that's also quite indicative. So I don't order it on everything. I certainly don't order it on any of the higher grade. And if it looks like a leiomyosarcoma, like a high grade or an intermediate grade, I don't order it then. I occasionally have some, sometimes you can get a very low grade leiomyosarcoma, and I'll order it in that situation as well, or a myofibroblastic tumor, or, a low grade myofibroblastic tumor. What was the other question?
Yeah, and the other question is about the differentiating melanoma. You know that some differentiating melanoma may look like rhabdomyosarcoma, even epithelial tumors. So what is your experience about on this case?
Yeah, no, I agree. And in fact, when I wrote the talk initially, I put a whole bit at the end about de-differentiating melanoma and showed all these examples that we had, that I'd had in Australia, because we get so many melanomas. And there are even places where, if a melanoma was to occur, like a nasopharyngeal one, they often show diffuse Desmond staining, which makes it really, like it's quite a trap, and can even be quite round cell looking. So you might mistake it for a rhabdomyosarcoma. And I put one on Twitter about 6 months ago of that. So that, it can be a real trap with melanoma, and you've got to just be thinking about it. And I think that's that whole bias of not even having it in your DD, to consider. So normally, unless it's a desmoplastic melanoma or a spindle cell melanoma, it should still be strongly positive for SOX10. I find SOX10 a really good stain because it usually doesn't stain many other things. I think the difference, often what you think about is an MP and ST or something like that, but with MP and ST, you don't see the same diffuse SOX10 staining. So I find SOX10 really helpful. For MP and ST, you'd be looking for focal SOX10 staining. So I find, like as a basic immunopanel, I would always include a SOX10. And I think some of that reflects living in Australia, because they're much more likely to see them. But it's a good clean stain, and it doesn't stain that many other things that you need to worry about in the DD.
Okay. Please, any further question or remarks to Dr. Fiona?
There's a lot in the chat.
Yes. You can check the chat, please. Is Empar Mayordomo?
I think no more questions.
Okay, thank you very much, Fiona. This was a really nice presentation. I'm pretty sure we all enjoyed of your presentation, and we continue with the next speaker. So our next speaker is Professor Samuel Navarro. He is Professor of Pathology from the University of Valencia and Pathology from Hospital Clinic from Valencia. He's a very important member of IMPERAS project in Spain, has many contributions in bone and soft tissue pathology and pediatric pathology. And of course, he's an expert in soft tissue pathology. And I'm very glad to have Samuel, because he, as well as Professor John Barr, were my mentor for my doctoral thesis. So I'm more than happy that Dr. Navarro present one case today for us. So Samuel, please, if you don't mind, can you share your screen and start your presentation? el audio.
Hola.
Hi. So, yes. Sí. Yes. This is okay.
Can you see the presentation?
Yes. Yes. But put in the code. Yeah. Yes. Fantastic. Thank you.
Well, okay. Hello. Good morning to everybody in Spain or occidental countries, and good evening to the friends Fiona and Cristina. It's so nice to meet you. Excellent presentations, Fiona. I like it very much. It was very educational, was very philosophical and very impressive, and the cases were very interesting. Okay, I would like to thanks Isidro and Cleo to invite me to participate in this IMPERAS final session of the 2021. Because my feeling is that this we need as a pathologist, not the Spanish pathologist, every pathologist needs a project like this, a project when we share our questions, our interesting cases, our to learn, to improve our work in the diagnosis of and the biology, the pathology of the soft tissue sarcomas. Okay, the case that I want to present is not a new fusion time, it's not a new entity, it's a classic one. It's a classic one, but put me under pressure because was a young people, a young guy, healthy guy, without any type of trauma, previous trauma, and especially because the surgeons, the oncologists, the radiologists made an undiagnosed approach of malignancy, and I was fighting them in the multidisciplinary team because I did not thought that this was a malignant case. Was I tell you, I was under excessive pressure, especially also because the young people, the young guy, the patient, was a relative, was very close to the family of one of our technicians. This all of the situations was in a hurry, as soon as possible, malignant versus benign. Okay, this is the case. The case briefly is a young man, healthy, without any antecedent, without any hereditary disease, without no previous local trauma. This is very important, or previous surgery. Suddenly present an intense pain, concealing and tenderness in the right inguinal area. This pain did very difficult to walk, the impossibility, the walk of the young people, and these symptoms arose in 2 weeks, since 2 weeks. Okay, the family very impressive. The clinicians did perform an image analysis and suspect, this is the very important and very pressure situation, suspect right a malignancy. Malignancy or malignant peripheral neck tumor, surface osteosarcoma. But there were the two main diagnoses of this case at clinical and MRI level. Okay, these are the images of the tumor or the tumor mass or the nodule in the bust in the inguinal area, irregular with no clear cut delimitations. Is inside the muscle, the bust, anterior bust, near of the pelvic bone. Is near of the great nerves and great bases of the inguinal region. Wow, impressive nodule with densifications, irregular densifications that were consistent with a diagnostic, clinical radiologic diagnostic of malignant disease. More pictures of the lesion. Here is a little reinforcement of the periphery of the tumor, the irregularity. Here, no, the limits are not very clearly defined, and the densifications inside and in the wall of the mass are evident. Okay, the clinician suspected something osteogenic, malignant. The clinician suspected also, because the location on the compression of the nerves, a malignant peripheral nerve sheath tumor. Then they perform a VII, 3 cylinders of a needle core biopsy, and these are the H&E features of the lesion. As you can see, we can observe rest of the soft tissue and aggregates of proliferating cells, more dense in some fields and less in another fields. But if we are looking deep into the cellular lesions, because they are a spindle cell with middle moderate atypia and a stroma, a myxoid stroma, not mitotic figures or nucleoli evident. Areas of the position of collagen or matrix or eosinophilic matrix. Okay, we thought that we could establish a diagnosis of malignancy with that images. I thought that it was a low-grade or benign lesion, and with this material, we will see that the third cylinder is more suspicious. I perform an unspecific diagnosis. I recognize that, but my initial diagnosis was a soft tissue tumor, fibromyxoid stroma, low grade. But I need more material to establish a diagnosis. For me, it was not a malignant peripheral nerve sheath tumor. For me, it was very difficult to diagnose with these features and surface periostic, periostal or parostal osteosarcoma, or even a soft tissue extraskeletal osteosarcoma. Okay, the third cylinder was a little more worried because we have several accumulations of tumor cells with this type of lesions, no marked atypia, but we can see this material, eosinophilic material between the cells that simulates osteoid matrix. The diagnosis of osteosarcoma was arising again, and we need more material because we need to establish the diagnosis, the differential diagnosis between osteosarcoma, parostal, surface osteosarcoma, soft tissue extraskeletal osteosarcoma, even another entity that could be malignant, could metastasize like ossifying fibromyxoid tumor. Okay, immunohistochemistry was absolutely unspecific. Only some cells express smooth muscle actin. S100 and SOX10 were evident negative. We discard the malignant peripheral nerve sheath tumor. TFE3 was also negative, talking about the ossifying fibromyxoid tumor. S100 also is expressing ossifying fibromyxoid tumor, and we only detected, but this is also inspecific, that the tumor cells express osteonectin, not is a remark for the diagnosis of osteosarcoma. Okay, we did immunohistochemistry on CDK4 and MDM2 that are related are observed in malignancies in surface osteosarcoma and were negative. And of course, we made the unspecific diagnostic of low fibromyxoid tumor could be benign. We don't believe that was an osteosarcoma. Okay, we look for another biopsy, a surgical biopsy, and the surgical biopsy was definitive, I think. Was definitive because this is the surgical biopsy, this is the periphery of the lesion, this is the center of the lesion. We can see the nodules, the cell nodules that we observed before, but together in a transition with bone formation mature and calcification on the periphery of the tumor. Okay, this is another image from the surgical open biopsy with the cell-rich areas similar to those observed before, and the peripheral of the lesion composed of bone, trabecula of bone with mineralization, showing us the typical zoning pattern. We can tell that we can observe that in the more cellular areas, some mild degree atypia, even nucleolized, and several typical mitosis were evident. It's another field of the tumor lesion of the more rich cells with the spindle-shaped cells, moderate atypia, scarce or some mitotic index, no necrosis, and the peripheral rim of bone formated trabecular bone, calcified bone with the classical typical zoning pattern. With this H&E, because we don't need anything more, our diagnosis was myositis ossificans, and we discard malignant lesions. Later on, past month, we in order to take out the diagnosis of ossifying fibromyxoid sarcoma or fibromyxoid tumor that has a specific fusion, we perform with the Oncomine Childhood Panel NGS, and we found in our case of myositis ossificans a fusion with the genes USP6 and collagen called 1A1. With these results, I suggested to the multidisciplinary team that we had to wait and see, not more treatment until surgical, if it's possible, surgical with radical excision of the lesion. 2 months ago, the tumor or the lesion was completely excised with margins free, and this is the pathology. This is the histopathology H&E from the definitive surgical remove lesion with the peripheral rim of ossifying bone trabeculae with mineralization and the more cellular spindle stromal cells that forming the very well-known pattern of zoning phenomena. Some fields of the surgical specimen show this typical image that remember us the existence of several cavities, blood filled with a fibrous wall, with giant cells, with bone formation that is characterized as bone aneurysmal bone cyst. These lesions have already been described in myositis ossificans, and all the community believe that these two lesions, especially the aneurysmal bone cyst of soft tissues, describe. There is a good paper of Rodriguez Peralta, our actual president of our society, regarding the description of the aneurysmal bone cyst of soft tissue that's very similar to our case. Regarding myositis ossificans, this is considered in the final edition of the 5th edition of the WHO classification of tumors as a benign, self-limited tumor of soft tissues, fibroblastic and myofibroblastic tumors with nodular fasciitis, with the fibrosis pseudotumor of digits, is considered benign tumor and self-limited tumor. Here we summarize our procedure in the differential diagnosis, because we consider in our case the possibility of nodular fasciitis that has clinical similar data. Also, the soft tissue, the above mentioned soft tissue aneurysmal bone cyst, the location, the clinical is very similar, and the true neoplasias, true malignant neoplasias, as soft tissue osteosarcoma, parostal, and ossifying fibromyxoid tumor. These are the clinical characteristics. One important morphological aspect of our case is the presence of zoning phenomena that characterize myositis ossificans. This fusion, we found this fusion in our case, USPS called 1A1, has been also described in related entities, benign self-limited entities like nodular fasciitis and soft tissue aneurysmal bone cyst. Ossifying fibromyxoid tumor shows another type of fissions and overexpression. We can demonstrate it by immunohistochemistry. The antibody is excellent. That involves TFE3, PHF1 genes. The immuno was different. Our immunohistochemic was completely unspecific. CDK4 MDM2 negative discard at least a little bit the malignancy of superficial or soft tissue osteosarcoma, as well as the ossifying fibromyxoid tumor was discarded on the basis also of the molecular biology and S100 negative, desmin negative, TFE3 negative. Okay, we summarize the term of myositis ossificans, as we know, is a benign, self-limiting disease that can occur at any age. Related, the majority of times with a previous trauma, sport, traumatic, surgeon, previous surgery, etc., but non-traumatic is already diagnosed. It's a self-limited lesion, benign, considered by the WHO book. The zoning phenomenon is diagnostic, but it's very difficult to establish this zonation, as happened with our case, if the material is scarce, like needle core biopsy, or if as happened in present case, that the biopsy was taken out, was performed in the 3rd week of the disease. It's very early to see this zonation pattern, this zonation phenomenon. Morphology like aneurysmal bone cyst can we see as we observed before, and myositis ossificans simulates bone and soft tissue sarcomas. The problem in our case was the pressure, was the hurry, was the as soon as possible, was the type of biopsy, was the time of performing the biopsy. And I tell all of you, I know that it's a common case, it's not a rare case, it's not a strange case, but I think this is a good case to learn about this problematic differential diagnosis that has already been published in several papers with the differences at clinical, radiological, or histological level within the myositis ossificans as osteogenic sarcoma, with ossifying fibromyxoid tumor that presents another type of fusion that involves PHF1 gene and TFF3 gene. We can detect in this type of tumor by immuno the protein, the nuclear protein TFA3. There are several recent papers regarding these novel recurrent fusions in that type of malignant tumor. USPCs has been described in the inflammatory process, in the angiogenesis and repair, etc., and has been published as we refer in several cases of aneurysmal bone cyst in nodular fasciitis, and myositis ossificans. Okay, our conclusions are very brief. The myositis ossificans is under the differential diagnosis with other soft tissue or bone tumors. The image and histopathologic diagnosis could be very difficult, above all, as happened in our case, in early stages of disease, if needle core biopsies are provided. These 3 entities, myositis ossificans, nodular fasciitis, and soft tissue aneurysmal bone cyst, are always related benign, self-limited entities that share not only morphological features, but also a common genetic profile. Thank you very much. I have to express my acknowledgement to my colleague in Lorena, that suffered with me this case and helped to me a lot, above all to help to avoid the pressure that we were exposed. Jose Gonzalez is our molecular biologist from the INCLIVA. He performed the NGS, and the chief of the traumatic service, the traumatology service, Professor Antonio Silvestre, a good friend, but in this case was an enemy. Thank you so much for your attention.
Thank you very much, Samuel, for this very nice case. I'm pretty sure we also enjoyed this case. I have 2 questions for you. Can you please stop to sharing your screen? It's in the top. ¿Puedes dejar de compartir la pantalla, Sam? Arriba, en ver opciones, dejar de compartir.
Vale.
Sí, gracias. Sam, I have Dr. Navarro, I have 2 questions for you. Do you think that some case previously diagnosis as myositis ossificans really, in fact, represent ossifying fibromyxoid tumor? That is my first question. You know that ossifying fibromyxoid tumor is a really emergent entity and share overlap some feature with myocytic ossificante? That is my first question. And my second question, do you think that nodular fasciitis, aneurysmal bone cyst, and myocytic ossificant represent the same entity with different spectrum, considering the overlapping morphology and they share the USP6 gene rearrangement?
The second question is for me is clear. These three entities are the members of the same family of genetically present the same profile with the USPS called 1AA and another gene fusions. Could be different locations of the diseases. Is the differences, but at morphological level could share some features that, and all of them are benign and self-limited lesions, and all of them could present a traumatic origin of an inflammatory process, reactive inflammatory process. Heterotopic ossification. And the first one is this new entity, the fibromyxoid ossifying. We share a case recently, you and me, remember. The problem of these cases is that the described ossifying fibromyxoid sarcoma could be malignant, could be present metastasis, and present another type of molecular profile. I don't believe that could be the same entity. If you, as happened in my case, because everybody were in a hurry, everybody was pressure. If you wait and see in a myositis ossificant, you can always remove the lesion. Even the lesion is completely calcified. That's happened in our case. Ossifying fibromyxoid tumor, I don't believe that spontaneously
regress. Okay. So, any further question? Cristina, Fiona, the attendees? I don't know. It's a question in the chat, Samuel. The radiology was not suspect the pathological diagnosis of ossifying myositis?
No, because there was not a traumatic antecedent. This is the question, and okay. Very rapid growth mass. I think that the problem in my case is that the biopsy was performed early.
Early, okay.
Because the early stages of this disease can simulate every malignant thing.
Okay. Any further question? Cristina, Fiona, do you have any question?
Okay.
Okay, Sam, thank you very much for your nice presentation. And we continue to our last speaker, is Professor Cristina Varga. She is consultant anatomical pathology from Douglas Hanley Moore Pathology, research affiliated for the University of Sydney. She has a special interest in soft tissue pathology, hematopathology. I'm glad because we share same interest in, but not breast pathology for me. And has many contributions in this field. She is very enthusiastic pathology, and we have a collaboration in progress between both teams. Hence, so we are very delighted to have Cristina on this session. I'm pretty sure we'll enjoy with your great presentation. So Cristina, if you don't mind.
Thanks, Isidro. Can you hear me well? I'll just share my screen now. Sorry, just a second. Can you see the full screen? Well, thank you so much for the invitation. That's very, very kind, and it's such a pleasure to be here. So I practice in Australia, but I'm originally Mexican, so I'm a Spanish speaker. So I enjoy the Spanish and the English part of the presentation today. So thanks so much for today. So the case, sorry, I'll just put the actual presentation. So this case was actually diagnosed in 2009, so over 10 years ago. So this is a female, 53 years, with 2-month history of neck mass and vocal cord palsy. At operation, there was an extensive mass infiltrating the thyroid and the perithyroid soft tissues, and the mass was over 100 millimeters in extent. We don't have any image of the macroscopic appearance, but these are the histological images. So you can see on low power some variation in some more hypercellular areas and some more hypocellular areas of spindle cells with some conspicuous vascular pattern. High power view on that area shows hemangiopericystoma like blood vessels, as you can appreciate. And then on the more hypocellular areas, some sort of myopericitomatous growth pattern around thickened wall vessels. Some really hypercellular areas, some more collagenous areas, presence of tumor necrosis in less than 50% of the tumor, and significant nerve entrapment throughout the mass. So really high grade, so that's just medium power to see the degree of cytological atypia and numerous extensive mitotic activity up to 30/10 high power field. So clearly a spindle cell, high grade spindle cell sarcoma. And I was asked to provide options to see what would be the initial differential diagnosis from the audience at this stage. Any suggestion from the audience in the chat? Okay. Anyway, so thanks. Yeah, so all the considerations are possible, and we have to still remember anaplastic, anaplastic thyrocarcinoma. So this is centered in the thyroid gland. The immunohistochemistry at the time is not very helpful, but we can obviously exclude a couple of differential diagnoses, excluding MPNST, spindle cell melanoma, sarcomatoid carcinoma, smooth muscle differentiation, clearly suspicious for a monophasic synovial sarcoma, but the FISH was negative. So the diagnosis at the time, and essentially excluding everything else, just fit with a primary fibrosarcoma of the thyroid gland, which have been reported. So that's only one case, but there have been series of cases in the thyroid gland. So that's truly the journey of the case. So that was 2009. And after 10 years with the presence of next generation immunohistochemistry, which is essentially just new biomarkers, we were able to get more insights into what this tumor is. So this tumor was actually, that was finalized, the diagnostic setting. The patient unfortunately died 6 months after the diagnosis, sorry, less than 6 months after the diagnosis. And now in 2019, we built a cohort for research. So there was a research sarcoma cohort using tissue microarrays. So this case was included as one of the cores or one of the cases, and we performed immunohistochemistry on that. So which stain was performed? So before we going into that specific stain, additional stains just done recently, not on the original case. So S100 and SOX10. So S100 was originally done, but the focal stain was originally missed. Now we pay attention to these things. SOX10 is completely negative. Again, probably no need to do it, but just the SS18 and SSX C-terminus for synovial sarcoma completely negative, excluding synovial sarcoma, as we know. H3K27ME3 is completely lost in the tumor, as you can see. And obviously that's raising the consideration of a malignant peripheral nerve sheath tumor. So we call H3K27ME3 loss plus focal S100. So what's truly the biomarker that I'm referring to? So there is an additional next generation, is just obviously for the fun of it, but it's a new biomarker that we perform on this case. And again, I don't know if somebody has any suggestion of what do you think we have done specifically? For some reason, I can't access the chat, but anyway, I'll have a look later. But for those who suggest pan-Trk immunostain, that's correct. So we perform pan-Trk immunohistochemistry using that specific clone. So you can actually see that this is on the full section of the tumor, so that's completely negative. But there were, and this is a good internal control because this is still detecting the nerve. This is the wild type protein, so that is detected by this clone. So we can still see positivity in the entrapped nerves within the tumor, completely negative outside. Is it really negative? So we look at other parts of the tumor and we noted the presence of really weak focal positivity in the cytoplasm of the tumor cells, and that's on high power. It definitely stayed present in approximately 5% of the tumor cells. So most of the tumor was negative. So luckily for this case, the actual core that we use for tissue microarray had extensive positivity for the pan-Trk antibody. So that was not the case for the full tumor, but that was just by chance that the TMA core had a strong stain in that single spot. So obviously in the context of research, that was suspicious for NTRK rearranged sarcoma. So a targeted NGS fusion panel was performed and confirmed the presence of NTRK1 gene fusion. So the final diagnosis 10 years later is that of an NTRK1 rearranged sarcoma with a fibrosarcoma MPNST-like pattern. We also perform array comparative genomic hybridization in this case, and you can see the results here as expected for a high-grade spindle cell sarcoma. It has a complex karyotype with gains, losses, and amplifications. And that was really part of a small research paper that we did, and I'll just discuss that in a minute. So this case, together with 5 additional sarcomas, are part of our first published experience in terms of the Australian cohort of adult sarcomas in the adult population. So the first paper on morphology and then a follow-up paper based on additional genomic analysis on those tumors. We know they have a fusion, but we don't know the genomic complexity of these tumors. So looking at those 6 cases, you can see they're completely different, but not only on the morphology. That's the array CGH traces for each one of the cases. So you can see quite diverse karyotype, essentially some of them showing high genome complexity similar to undifferentiated pleomorphic sarcomas, but some other ones really simple karyotype. And that was associated with clinical behavior as well. So these cases, most of them have follow-up. And the cases with, as expectedly, with complex karyotype had advanced disease at presentation, metastatic disease, and the ones with simple karyotype were more indolent, so like these cases present in the subcutaneous tissue. So we thought that translocation-associated sarcomas show a relatively simple karyotype, so such as Ewing sarcoma, synovial sarcoma. We know that they tend to have only the gene translocation and not much of additional mutations or copy number variation. But that's not really the case for NTRK rearranged sarcomas. They're quite different. So just a brief review. So we know there are 3 tyrosine kinase genes. They encode the TRK A, B, and C proteins. They have a key role in central and peripheral nervous system development. They lead to activation of the MAP kinase and PIK3CA downstream pathways. So that's in the wild type, but also when they are activated due to gene fusions. So the first described were in infantile fibrosarcoma, cellular mesoblasthic nephroma, and secretory carcinoma of the breast. That was the ETV6 NTRK3. And why is it important to recognize the presence of NTRK fusions in a tumor? Well, we know that there are pan-Trk inhibitors, and the degree of response to this tumor is quite significant. So the overall response can be 75% across all solid tumors, so that's including carcinomas, but 88% for sarcomas is quite significant. So this is one of the cases from our series. This is courtesy of Professor Anthony Gill. This is actually a metastatic sarcoma this is in the lung. But the patient developed widely spread metastatic disease early on in a period of 6 months to essentially systemic involvement. So she received treatment with entrectinib, and they identified 50% reduction in metastatic deposits within a month. I believe the patient is actually still alive after 2 years. So the response to these sarcomas is really significant. So we need to identify, particularly in young people, the presence of these NTRK rearrangements. So you can see just the side about this case, the immunophenotype, again, is 100 focally positive, SOX10 negative, CD34 negative, which is a clue, the presence of CD34 positivity, but again, in this case, it was also negative. This had a little bit of SMA, and the H3K27ME3 is retained. So the histology for this tumor is so diverse. Can be high or low grade, like adult type fibrosarcoma, could be high grade MPNST-like, can be low grade MPNST-like. It mimics completely an inflammatory myofibroblastic tumor, could be quite hemangioparasitic or myopericytoma-like pattern, particularly for NTRK1. So lipofibromatosis-like pattern, also for NTRK1. So that's the image of the original description by Antonescu's group for the lipofibromatosis-like pattern. And this is our case of an inflammatory myofibroblastic tumor-like pattern with the scattered inflammatory cells in the background, even germinal center formation. We also have to remember now that this morphology is shared by all kinase gene fusion positive sarcomas. So this is not exclusive for NTRK. So essentially translocations involving MET, ALK, RAF, BRAF, RET, they may share most of these patterns, including the staining pattern for SOX10 S100 and CD34. So more morphological variation in cases report. This is a uterine tumor, completely low grade, no atypia whatsoever, the presence of prominent vessels with hyalinized and sclerosed wall. And also from our department, so Professor Fiona McLean, so she actually identified the presence of a perineurioma-like pattern in tumors arising in the retroperitoneum and raising the possibility of a dedifferentiated liposarcoma, areas of low-grade dedifferentiation, where the MDN2 came up negative. So then she performed a pan-Trk immunostain on the first case, on a case that she had, and she identified positive stain. Then the FISH confirmed the NTRK translocation. And on a second case, the pan-Trk immunostain was completely negative, but the FISH was performed and confirmed again the presence of NTRK rearrangement, even in the absence of immunostaining. So that's a manuscript in preparation by Fiona and Vanessa Young. In fact, can we even have primitive round cell pattern? Yes, we can also see it. So this is, again, one of our cases as well of a toe amputation in the soft tissue, showing a round cell, a little bit of spindle morphology, extensive necrosis and mitosis. You can see the staining pattern for C99, NKX 2.2, and you can obviously guess because I know you guys are experts in Ewing sarcoma. So confirm the EWSR1 FLY1 fusion. But again, in tissue microarrays, we identify staining for pan-Trk antibodies. So we can see that in Ewing's doesn't make it NTRK because Ewing sarcoma can show cross reactivity with pan-Trk antibody. But in this case, we performed FISH, which was not diagnostic. So it had an atypical pattern, not diagnostic, but NGS showed the presence of an NTRK2 fusion. Again, so we published this as a case report for a double hit translocation sarcoma showing actually EWSR1 and an NTRK2 fusion. So based on histology, obviously we can predict some cases with NTRK translocations, but not in a significant proportion. And the diversity is just increasing, the morphological diversity. A clue to the recognition, well described in the literature, is a CD34 positive, S100, usually patchy and SOX10 negative. We know that all other kinase fusion sarcomas are going to share this. And also we need to be careful not to misinterpret the S100 at mixed dendritic cells as lesional cells. So recommendation also from this paper to distinguish from MPNST is based on the SOX10 negative and H3K27ME3 retained for NTRK. And basically on those series, all cases had H3K27ME3 retained, but that was not seen in our case. So we had loss as well, which still fits with that MPNST-like pattern that can be seen in NTRK. So the antibody still is a good first line for screening. So that clone recognizes the wild type TRK A to C proteins. The problem is well recognized in the largest series that the specificity and sensitivity in sarcomas is poor, 80% and 74%. Positive stain can be seen anywhere in the cell, depending on the gene fusion partner. False positive expression can be in a range of tumors, so smooth muscle, round blue cell tumors, including B-core, Ewing's, and sometimes truly the functional protein still produces a background very high level of stain. And in some cases, and particularly the case that I just highlighted today, PANTRAC can be very weak and very focal, so less than 5% of the cells are going to show it. So that's why they still consider in this reference that I'll show you 1% to consider it positive. So this is actually the largest series that assess immunohistochemistry. The number of cases is quite large, 33,997 cases. That was just published in Modern Pathology last year by Solomon. It's an amazing paper with large number of cases. The problem is and these cases were all sequenced. So they all have sequencing, but then retrospectively, then they did immunohistochemistry. So only 70 cases, around 70 cases of all of those had actually NTRK rearrangement. So you can see how rare these are. So these are a range of solid tumors, so carcinomas and tumors from everywhere, not just sarcomas. And then after doing the immunohistochemistry, you can see the sensitivity based on the NTRK gene. So it's actually lower for NTRK3 and much higher for NTRK1 and 2. But if you look at the total numbers of cases for NTRK2, 100% sensitivity, but it's only 5 cases that were assessed. And so on, so 27 and 34. So that's just really showing us that we don't really have enough experience with the antibody, even in the largest series of cases. And in the common everyday practice, I find it a very difficult antibody. Because again, I don't know if I'm looking at true false positive or maybe false negative stain, I just don't know. But I think one of the important messages in these cases is that for undifferentiated tumors, undifferentiated sarcomas, I think we need to consider NTRK sequencing, immunohistochemistry and sequencing, FISH if possible. So not really time to talk about molecular testing, but RNA-based sequencing is the optimal approach. It's better than DNA sequencing, which actually it can have 20% of absence of detection. And even FISH can also miss around 30% of gene fusions because they have a high incidence of intrachromosomal fusions, like small deletions. They have a very small narrow split on FISH. And that's the talk for today. I just want to acknowledge my supervisors and mentors and who participated in all these projects. And so obviously Professor Fiona McLean and Professor Anthony Gill, who also provided some of the funding for that NGS that I showed. Also, that ARRAY-CH study was funded by a research grant that we obtained a year ago, which is called Hannah's Chance Foundation. So Hannah died of synovial sarcoma, age 19, and the family provides small grants for people doing research. And in this case, as pathologists, we were very lucky to get that grant. Gracias por su atención. Any question? And I'll stop sharing.
Thank you very much, Cristina, for your nice case, your nice presentation. So this is beautiful to have additional targeted therapy for instance, during sarcoma. I wasn't aware of this additional gene fusion included in NTRK during sarcoma. So we have additional targeted therapy for this patient. I have only one question. As you very nicely described your case, display loss of the histone protein, the A3K27 methylation, and focal S-Hander expression. Do you continue to call this case NTRK sarcoma or malignant peripheral tumor with NTRK alteration?
Oh, I don't think there is a good answer for that. That's a very good question. I don't know how the nomenclature is going to evolve for these tumors. Yeah, this is a very interesting point. So I think we're going to see a lot of it in the next 5 years because we are going to see fully classified tumors, including leiomyosarcomas. A proportion of leiomyosarcomas can actually show NTRK rearrangements. And what the nomenclature is going to look like, I think we just don't know yet. And both may be valid as long as we make sure that they understand that there is a driving gene alteration. So yeah, I don't know the answer to that, but that's very good. We'll see that. We'll see that in the years to come.
Okay, we have some question in the chat. Can you see the chat?
Yes.
There is a question from Fiona.
Yeah, so do you think the platform matters for how sensitive specific the pan-Trk immunohistochemistry is? It's very likely that's the case. The platforms, the different staining systems show significant variation. For sure, we have two antibodies. I mean, sorry, before answering to this, about the antibody, about the actual clone. And I showed in the presentation, so sorry I didn't emphasize on that, but there is significant variation in the two clones, significant variation. We saw it with a few cases here, and in fact, the degree of the percentage of positive cells and the intensity with the other clone is significantly higher. So you could see 100% stain with the other clone, and with this EP clone that we use here, the one that I presented, the percentage of cells and intensity got to like 10% 1+, and with the other antibody would be 90% 3+. The problem is the other antibody, which again is in the talk, is associated with more false positive detection. So that's not very specific antibody. So that's one thing. So yeah, variation amongst the clones, and I'm only aware of those two clones. And in terms of the platforms, again, we just don't have literature. So that largest study, I don't think we even have details about the actual platform. So yeah, so largest study with 70 cases, and we don't really know.
Okay, any further questions? Rimar? Fiona? Samuel? Do you have any question? No? So Cristina, thank you very much. Thank you very much to Dr. Samuela, Dr. Fiona also. And we really enjoy pretty much this session because there was a combination between morphology and molecular analysis of the sarcoma tumor and the importance of integration for the result for an accurate diagnosis. So we hopefully to see you soon in the near future session in sarcoma, in this sarcoma session. And we have our next session in January with European guest speaker, but of course, we also send you the invitation and the Zoom link to participate in this session if you have time. And
we'll be joining. Thank you so much.
And one more, we really appreciate your time to connect and to join this session because we know that these are 10 hours ahead in Australia, Sydney. So have a good night and good morning to all the attendees and see you soon in next section. Thank you to all of you.
Thank you so much. Bye-bye.